It's my pleasure to introduce Cecelia Roscigno, and she is assistant professor in the School of Nursing. And I really like the idea of getting faculty from School of Nursing over here, exercise and sports science, so we can talk about our common areas of interest. That's kind of the role that centers play on campuses, that kind of cross-pollination role. And at the end of the day, our patients are more than just a constellation of illnesses and injuries, right? They're actually people. And that's what really appeals to me about Cecilia's work, I think, is that she's, we hear a lot about patient-oriented outcomes, but she's really actually doing patient-oriented research where we actually get the perspective of an individual family and how, no one would argue that our systems are perfect. We know they're fragmented in many ways, but maybe we can see how to improve them by looking at them through this lens. So I hope I've sufficiently misrepresented your work, that you can correct everyone's misapprehensions. And Cecilia, are you going to take questions as you go along?
At the end.
Good.
So thank you for inviting me, everybody. It's really my pleasure to connect with other people who have a passion for this area of research, because I've been doing it for 15 years now, and I've been very fortunate to have various people along the way who have been able to help me with various aspects of what I'm doing, but I haven't always been able to work on a team, and that really appeals to me, to find other people that want to do this kind of research. So just to give you a little bit of background, I've had more than 35 years in healthcare, both civilian and military. And in 1989, my husband got out of the military. I got out a little bit before him, and then he got out, and we decided we wanted to go back to school. So we moved to Gainesville, Florida, because we researched schools that were good schools, plus that we could afford, because we were both going to be putting ourselves back through school. And we decided the University of Florida was a great place to go in Gainesville, Florida. And I'm actually really grateful that I did that, because it turned out I got an awesome education. And the further I go along, the more I realize that I had an awesome education there. So I went there, and through my education, I started becoming interested in patients, especially children, with neurological conditions and neurosurgical conditions. So when I graduated, I decided to go in pediatrics, and that was an area I had never worked before. I always thought, ooh, pediatrics, that's so scary, and that's so depressing. I get that all the time. People say, how do you work in that area? Isn't that depressing? And I would say, absolutely not. Children are amazing, they're resilient, and you learn so much from working with them. And one of the things that appealed to me is that was an area that was in the forefront of being patient and family-centered care. And that really appealed to me, because I had always worked with adults, and we were not always doing that so well. So I worked at the University of Florida at Shands Children's Hospital, and was able to start working with a lot of these patients that I loved working with, because a lot of my peers didn't actually like working with those patients. They were kind of scared of them, or they found it very, the care was a lot of the care was total care, and they didn't like working with those patients. So every time I was working, they were like, Celia's here, give her those patients. And I was like, okay, that's great, that's fine with me. And then in 2000, before 2000, I decided to apply to the University of Washington's graduate program, because they were the only school in the country that had this master's program where you could focus in neurosciences, and that's what I knew I wanted to do. And so I applied. It was an adult program, though, and I wrote to them before I applied, and I said, look, I'm really interested in this neuroscience program that you have. However, I don't want to focus in adults. I want to focus with children. If I got accepted, would you let me tailor the program to make it pediatrics? And they were like, absolutely, So I applied, and much to my surprise, I got accepted. And so I was able to tailor my program. I took courses in the whole neurobiology series, and cognitive neuropsychology series, development, psychology, brain development, all that type of coursework. So I got a really strong background in the neurosciences to help me focus in that area. And then I was also working at Seattle Children's Hospital at the same time. And I was also working with Monica Vavalala, who is now the director of the Injury Prevention Center in Seattle, Washington. And she was doing some physiologic research with traumatic brain injury, and that's what I was interested in, physiologic research. So, and I thought that I was going to do my PhD focusing on that, the same work that I had done for my master's, which was cerebral perfusion pressure levels in children with traumatic brain injury. And then one of my peers was taking a course in qualitative methods, and I had always taken all these courses where I was solo and with all these people that didn't know me and didn't share my interest as a nurse. They were neurobiology majors. So they, being able to take a class with a friend really appealed to me. And I thought, oh yeah, I'll take that class, and who knows, someday I might have to review a qualitative research study. So that makes sense, but I have to admit I was pretty arrogant and ignorant about qualitative research, and I thought, that's for people that can't do real research. And so I took this course with a little bit of an attitude when I started. And it wasn't until I got partway through the first semester of this 2-semester course that the light bulb went off, and I thought, oh my God, wait a second. My ignorance is part of the problem, and actually qualitative research would be amazing to do in this area, because how can I understand what it's like to, as an able-bodied person to be disabled? How can I understand what it's like to be a child and experience this? So maybe, as a matter of fact, this is exactly what needs to be done. And so I did a complete turnaround and said, wait a second, I actually think this is what needs to be done in this area. So for those of you, you know traumatic brain injury, and I don't need to go into this too much. It's a huge problem. There's a lot of children that are injured every year that are hospitalized. And if they survive, they have a heterogeneous range of problems. There's this underlying assumption, if you read a lot of the literature, that the majority of family stressors in managing and adapting to the condition are related to the child's injuries or the family's coping. Yet, we've never really bothered to really look at what do these families have to cope with, and how might healthcare be contributing to that problem. So we needed to do this particular research. So I wrote an NRSA that was funded on the first round, and initially I was actually really more interested in the children's perspective. I was going to be interviewing both children and parents, but I was really only interviewing the parents because I thought, well, in order to understand the children's perspective, you have to also understand what's going on with the parents. But I didn't really understand that, no, I need to understand the parents' experience as a unique and individual thing. So when I first conceptualized the study, I was going to do 20 families. But as I got into it and I started hearing the parents' stories, I went back to my mentor and said, oh my God, you wouldn't believe these stories that they're telling me about how, first off, healthcare is a problem, how going back to school is a problem, how getting back into the community is a problem. And I never realized that, these things are such problems because I worked in early acute care. And wait a second, these parents have important things that we need to listen to. So I actually realized that their perspective was very, very important, and that I needed to value that. And I also realized that I needed to make sure that I captured maybe a bigger sample. So originally I was recruiting locally, and I decided I wanted to recruit from across the nation. So I wrote a whole bunch of smaller grants to help me start going out and get people from across the nation. So I actually recruited from across the United States, from 13 states, and they were enrolled between 4 months and 3 years. I only had one person who was at 4 months post-injury and one person who was 3 years post-injury. Most of them were in that middle point. And then they were between 8 years and 20 years of age at enrollment. They had to be able to consent and participate in an interview. That was important, of course. And at least one parent had to participate. And I used descriptive phenomenology, which is a qualitative methodology that posits that those who live through something are the ones who really understand it, as opposed to those of us who are clinicians and work with traumatic brain injury, or those of us who do research with traumatic brain injury. So you put forth the people who experience it in the forefront, and you try to hold back what it is you think you know about it. And so I conducted two 90-minute interviews. A lot of them were a lot longer than that, but they were at least 90 minutes long. And they were a range of 15 months post-injury and, a mean of 15 months post-injury and then 27 months post-injury. And so there were 6 main children's themes, and I'm just going to kind of summarize them. You know, the children had to deal with major changes that they went through, which were difficult for them to come to terms with, especially in the first interviews. This was when I really heard a lot about this. The interviews were actually very depressing, and I found I had to have somebody I could go talk to after I conducted the interviews, because it was very difficult to, as a nurse, and I wanted to do something to help these people, and as a researcher, that's not your role to do that. And so that was very difficult to be in that place. And they talked about the changes. These were very bright children who then had to work very, very hard to do very, very simple things. But what was interesting was these last 2 themes. It's not all bad. Some people get it, but many people do not. In the second interviews, their perspective changed quite drastically, and they suddenly had this positive outlook on life, even though they were dealing with some difficult things. But they said that other people around them had a very difficult time understanding that, and they really focused on the negative and what they had lost. And so this became an important thing that I realized I need to go back at some point and do a secondary analysis to find out what's going on with that. So you'll hear a little bit more about that later. Then the parents' themes were very important, and I'm just going to kind of summarize that. Parents were going through this grieving process and the struggling to get the things that they need, but at the same time they were attempting to be resilient and looking for positive ways to move forward. And why might that be important? Because those of us who work in healthcare, and even people out in the community, focus very much on the negative. And when they show signs of resilience, people tend to think they're out of touch with reality, or their expectations are unrealistic. And so parents said that that's very hard to deal with when you're trying to help your child and help your family, and you have people who are out there supposedly helping you that have that point of view. So again, I knew these other themes that I needed to go back and do some secondary analysis that would get at these things, because I couldn't do it in these 2 papers that came out for these 2 general studies. So I'll talk a little about that in a little while. Then I went to do a postdoctoral fellowship at the University of Illinois Chicago. And those of you that do research know you always have to move on and do something new, learn something new, do a new study. If you want to focus on something you've already done, that's okay, but you kind of got to do that, in the background and focus on something new. So I actually was at a conference presenting my data, and Dr. Karen Cavanaugh, who's a nurse researcher at the University of Illinois Chicago, came up to me after I was presenting the parent data and said, I do this research with a similar but very different population, parents who are at risk of delivering an extremely premature neonate. And she said, my parents are saying almost the exact same thing you were talking about. She was like, is there any way you would be interested in coming doing a postdoc at UIC? So they had a Irving B. Harris Foundation fellowship that I applied for, and I got accepted. And so I went there to work with her, and she had this NINR-R1 study that was interviewing parents who are at risk of delivering an extremely premature neonate. They were in the hospital, and they had 40 women, and it was a multiple case study where they had the women, they had some of their partners, and then 71 healthcare providers that included physicians, neonatal nurse practitioners, and staff nurses. They had this encounter where they discussed, this is, you're at risk for delivering an extremely premature neonate, this is what we think, this is what the issues could be. And then they went and they interviewed the parents separately and they interviewed the providers separately. And then we wanted to look at that data and see how are they each looking at that encounter. You know, quite often healthcare providers thought they gave broad information, really explained things thoroughly, but parents didn't always agree. And so we were able to look at that using content analysis. We wanted to talk about this issue of hope and how parents view hope and how providers looked at hope, because that seemed to be a really important issue in these conversations. So the parents' findings, they needed to hear the full range of information, and they didn't feel healthcare providers always did that. They focused on medical information. They didn't always tell them about what is the long-term outcomes of these children. How do other parents deal with this? How do other parents feel about this? They wanted to hear much more information than they felt they were always given. Then they also said, you know, they needed to know that every chance was given to the infant. And what was important about this was that we realized that even though healthcare providers were still doing things for these infants, the way they had these conversations gave parents the impression that they might be giving up on the infant, which caused them extreme distress. And so we realized we need to help healthcare providers understand how to give this information, because you don't want the parents thinking you're giving up on the infant. So the other thing that came out of it was parents' culture was on hope, was that to be a good parent, you don't give up hope until there's absolutely nothing left to give you any hope. And that was really important, because when I talk about the provider findings, we orient to hope much, much differently. And so this notion of being a good parent came out of that, and how do parents orient to being a good parent. And they talked about relying on their spirituality, and by this, although some people for spirituality might be religion, for many of these families they did not consider themselves religious, but they felt there might be a bigger meaning to being a parent, and why making these decisions were really, really important, and that we needed to understand that. And then, because these were longitudinal interviews, parents could look back and say, well, now wait a minute, the outcome you told me my child was going to have was a lot different than the outcome we actually had. Therefore, you need to be really, really careful about how you have these conversations. You need to be willing to discuss uncertainty. You need to be willing to discuss the precision of our ability to make these prognostications. So then the providers' findings. Providers related to hope based on the child's outcome. If they felt the child's outcome might be good, then they were willing to make positive references. But if they felt their child's outcome might be bad, and to healthcare providers, disability is a bad thing, then they did not think hope was warranted. And then they talked about being influenced by their daily culture, and that you deal with death, disability, trauma, that working in these environments influences how you think about these things. And they really talked about struggling with what's the right thing to do about, should you give hope, or is there such a thing as false hope? And so we wrote a paper on this that came out in 2012 about this whole notion of hope and how it influences these conversations. So then at the same time I was doing this postdoc, I was invited to do a fellowship at the Rehab Institute of Chicago as a disability ethics scholar. And we had to do a project, and so being somebody who does research and knowing that publications are always seen as important, I decided to do a lit review. After reading this paper, Disability, Constructed Vulnerability, and Socially Conscious Palliative Care, written by Dr. Carol Gill, who is a disability studies scholar, and she's a person who was born with, or not born with, she had polio, and she's been wheelchair bound since a child. And she's a beautiful writer and really thoughtful scholar. And we read this paper, and she talks about how vulnerability can be constructed in healthcare systems. And she gave some personal narratives of situations she's been in. Some of them were related to nursing, and they really moved me. And I thought, I know my colleagues, none of us ever set out to be insensitive or mean to people. However, I also know we do a lot of things that are insensitive and mean. And what could I do that might help change that? So I wanted to do a literature review looking for first-person narratives of bad healthcare encounters to find what could I find out about that could help educate my peers. So I did this lit review using research articles, but I also used some non-traditional sources to help make that a little bit richer, and use narrative analysis. And I'm not going to go into the themes just because of the time and that we have, but basically we're not doing a good job of listening, and we say and do a lot of insensitive things to these people. And it really validated what she was saying, that a lot of people avoid care or are really angry at the care that they receive because it can be very insensitive. And so I published this in Journal of Neuroscience Nursing, which I now regret because it wasn't the right audience, because it isn't just a nursing problem, it's actually a healthcare provider problem. So I told you about those secondary analysis that I wanted to do with my TBI data, and I finally was at a point where I could do that in the background of other things that I was doing. And so I wanted one of the secondary analysis that I wanted to do was communication in early acute care related to severe TBI. The families with moderate TBI, although they had an occasional insensitive thing said to them, overall they were pleased with the information they were given and the encounters that they have. So they didn't have a lot of complaints, but persons with severe TBI had a lot of strong reactions to the communication that they experienced. So I wanted to find a methodology that would get at that was a communication methodology that could really help me. And I happened upon this method, ethnography of speaking, which it turned out was not developed by, but further enhanced by the person who taught that qualitative method course that I took. And it was funny because it was the very first thing that he taught us, and as I told you, I was a little bit arrogant and ignorant. So it kind of went right over my head when he first taught it, because I was really at a point where I was going, do I even believe in this stuff? Do I think this is good research? And so I didn't really absorb it at the time that I took the course, but I went back, I luckily had my book, went back, reread everything, found some new articles that he had published, and I finally contacted him and said, look, I'm going to be coming back to Seattle to visit my daughter, and here's what I've been working on since taking your class, and I really think this method could help me, but I want to show you some of my data and see what you think and know if you would be willing to work with me in the future. And he was very excited. So we met, and I showed him the data, and he was really excited about it. He was like, I would love to see this applied in such a pragmatic manner that I know you have to go and look for some funding, but even if you don't get funding, I'm willing to work with you because I really want to see this happen. So I want to tell you a little bit about ethnography of speaking. It posits that people consciously and unconsciously structure their own talk and react to other people's talk based on their attitudes, beliefs, notions, or expectations, which is the definition of culture. And we often don't think of medicine as a culture, but we have our own set of symbols, we have our own language. It is very much a culture, and those people outside of medicine very much see it as a culture and react sometimes to it. So it made perfect sense to use this methodology, I thought, and he was really excited to work with me. So it uses discourse analysis guided by this speaking framework, but it's different from critical discourse analysis, which a lot of people have heard about. It doesn't take a judgmental stance. It's really just using it so that you can come to an understanding of what might be going on. So I did get a small amount of funding from the Society of Pediatric Nurses to give him a token fee for his consultation, but he really did help me out mostly on his own. And I was able to work with Dr. Teresa Savage, who's a pediatric nurse, but she primarily functions as a bioethicist. And she was really interested in this study, so she worked with me as well. So we coded line by line. You pay attention to the words used, how the words are used, but you also pay attention to nonverbals and paralinguistics. So I was able to go back into the data from the audio recorded, and put some of that stuff in to help out. So that paralinguistics are emphasis on particular words. So when I say stop, or I say stop, you get completely different meaning from those two words just from those paralinguistics. So we aren't always aware of it, but we do pay attention to those things when we're listening to somebody. And so that was really important because that would help us understand how parents are making meaning of these encounters. So we coded them, but we used Dr. Phillipson as our peer reviewer because he was a method expert. And I really liked the fact that he was not in healthcare because I thought myself and Dr. Savage were both peds nurses. You know, we're both in healthcare for years. We might orient to this data quite differently than an outsider might. And there were a few times that he pointed something out to us that we hadn't thought, you know, we browsed right over it and he said, what about this? You know, so that was really good. He was able to point some things out to us. And then Dr. Gerald Grant is a neurosurgeon who has to have these conversations. And I had worked with him when he was a chief resident at Seattle Children's and Harborview Medical Center. And he was here at Duke quite serendipitously, and it was like, I can't believe it, because if somebody asked me, you can work with any neurosurgeon in the world, I would have asked for him, and I couldn't believe that he was here when I came here. So that just felt like, wow, this is meant to be. And he was really excited about this research, so he wanted to work on it as well. So he was able to act as a clinical reviewer, and also because we were both nurses and we were dealing with encounters that involved both nurses and physicians, I didn't want anybody to perceive that as nurses we were bashing doctors or anything. So he was able to add that point of view as well and point out things from their perspective. So, and we also had, in the second interviews, talked to the parents about these communication issues so they were able to weigh in on them. But we also sent them copies of the final manuscript. So we actually ended up taking this data and we split it into two papers because it was so rich. And we all agreed that there was so much information here that it needed to be split into two separate papers. So one paper just talked about communication as a whole within early acute care and how that shaped parents' perceptions of a place, which is the physical, cultural, spiritual, psychological setting that you're involved. But then we also, the second paper just focused in on prognostic talk, and it's very similar to that paper that I did with parents at risk of delivering extremely premature neonates. So how talk was situated? Well, parents talked about there's a lot of policies, whether it's visiting policies or other policies, that keep parents from being at the child's bedside. And if you can't be at the child's bedside, well, you also can't be where talk is happening. So they said they were automatically disadvantaged by things like that. But then also, regular discussions didn't happen with key people because some of the key people are surgical services and they come around at 5:30 in the morning, and if you don't happen to be at the bedside, then they're in surgery all day and you might not be able to get with them. And so they talked about these other things that tend to disadvantage them. And unfortunately, not all nurses were aware of what the plan was or what was going on or knew how to help the family, so that was an issue. But then they talked about updated, timely information being explained. There's a difference between telling somebody something and explaining it to them, which means that you use a language they can understand. You might need to use multiple ways of explaining it to them, visual, audio, drawing pictures. So that was another thing. And then they talked about social expectations for talk in this place. So in other words, they weren't aware of it when they came into this setting, but there are expectations of the way you have these conversations. And it wasn't until it went wrong, usually, that then they became aware of, oh, wait a second, that's not how you have this conversation. And so there were a lot of narratives where parents were reacting to the right way to do something like this is. And I actually give you an example in a little while. And then they talked about parent involvement in decisions. While we claim we often give family-centered care, sometimes parents said people came to them and really the decision had already been kind of made and they were just being expected to agree with the decision, that they weren't really involved in putting all the information together, that things that were important to them weren't always considered. And so we were able to help highlight that. And that paper came out in 2013. Oops. So then the prognostic talk paper focused on just that difficult conversation where you're talking about what might be going on, what might the future hold. And so parents talked about that the delivery of prognostic talk often disadvantaged them. First off, it was often very complex. We used a lot of jargon. But then there was a lot of information that was given to these parents, and it's very emotional information. And if you know anything about the brain, what happens is when you overload somebody with very emotional information, they stop processing. They're focusing on maybe that one thing that you said, like brain bleed, and all of a sudden they're not hearing the rest of the stuff that you said, and you've lost them. So we realized we've got to change the way we have these conversations to make it a little bit easier for these persons. Providers often overemphasize the negative and didn't always give positive stories. Truth-telling, they said, involves talking about all possibilities, including positive. And it wasn't that they wanted you to focus on positive, they just wanted to hear the full range of things. And that stressing the negative with certainty can actually fracture relationships. So when families felt they weren't being told all of the information, they often went to other people. And sometimes they went to other people that were completely out of that system of care because they wanted to find somebody who could sit down with them and discuss all of the information. And clearly we don't want that to be happening. Parents needed to think positively. This is much like the other parents said, that to be a good parent is to not give up until it's absolutely, there's no other possibility. And so to be a good parent, you have to hold on to hope. And then they said, again, because this was a longitudinal study, they said, wait a second, most of the parents said, who were given negative certainty, which was 16 out of the 23, 14 of those parents said, my outcomes were very different from what I was told. And the other two said, they weren't completely different, but I still disagree with the way the information was given. That I still say you should give all of the full range of information and have those discussions with families. So both of those papers were published. And this is a speaking framework. I'm not going to go through it, but just in case, these are going to be posted, I know, in case anybody wanted to look at what this speaking framework really looks at, because it is pretty complex. And just to give you an example of particular this expectation for how things should be done, I'll try to read it as it was said. So this is a mom responding to, she's in the surgical waiting area. You're waiting anywhere from 2 to even more hours because those surgeries can be very long. And you don't even know if your child's going to make it through it. And then the doctor comes out, and so she's reacting to the way he responded. So she said, first thing he did not tell me was, your daughter's doing fine. He goes, what kind of insurance do you have? I was blown away at that point. I said, how is she? Oh, she's fine, da-da-da-da-da. But who do you go through? We need your insurance information. I'm like, right now, I could care less about insurance. So I was very blown away by that. And I said, so if you would have known my daughter had this insurance, because I told him what it was, and he was like, would you have done a half-assed job? And I walked away. I was pissed. I was very upset. So you can see from this how she's saying there's a very particular way that you should do that. Now, I don't think this doctor probably was just caught up in his own reality, and he's thinking, I need to know the insurance because I've got to figure out what the plan of care can be. And he probably didn't mean to be insensitive. But the mom is saying there's a particular way that you have these conversations, and you need to understand that the first thing I need to know is he alive, is he okay? And if you don't do that, I'm going to think that you're very insensitive, not only from the words that he said, but some of the nonverbals that he did. And so we need to be mindful of that. So then I came here to do, believe it or not, a second postdoc, and because they had the interventions for prevention and management of chronic illness, and I wanted to work with Dr. Knappel, who's in the audience. Kathy, can you raise your hand? Because she has done years of work with families of children with chronic illness. And so I thought, geez, this is definitely what I need to start moving into this area in order to help these families. So I knew I wanted to learn about designing interventions. However, I also was mindful of the fact that doing an intervention to change behavior of healthcare providers, which I knew is what needed to be done, is extremely difficult. And I might not be at that point quite yet. However, at some point I'm hoping that I can do that. So she had an NINR study that had just gotten funded. It was a mixed method synthesis of published data on childhood chronic conditions with family. And one of the conditions initially was traumatic brain injury. So it made sense for me to connect with her and that I could start extracting that data for her. So I'm going to come back to that because I started extracting that data, but then I was also doing some other things on the side. Remember I told you about those other secondary analyses that I wanted to do. So one of them was school reintegration, which was, parents had a lot of stories to tell. And I had a really interesting sample because not only did they go to public school, but I had several that went to private school and I had some homeschooled. And there were no studies out there that talked about those unique issues. So I thought, this is actually a really important paper that could come out of this. And so I want to present this data. So this was the full study, both moderate and severe traumatic brain injury, that was included in this. And one of the things I really like about this paper is I was able to take Braun from Brenner's ecological model, which looks at the individual, the family, the community, and the larger society, politics, culture, and show how those things interact with each other to influence people's everyday life. And so we have one table in that paper that shows how school reintegration was different for each family based on some of those various things. And then we also had 4 themes and sub-themes within them about the things that parents had to deal with in school reintegration. And so one of the biggest things was, even though we have all these laws out there to make school reintegration and to help these families and children, laws don't change attitudes and behaviors, unfortunately. And so families struggled with some people who didn't really understand why these laws were out there and how it could help or hinder children. So, and then parents wanted to be involved in these decisions and help and they could bring important information to teachers, but they weren't always listened to. And then parents who homeschooled had very different experiences, which we were able to talk about, because they don't have anybody to help them learn how to change that teaching to that particular child because of the issues that they have now. And then parents reported that when school leadership and collaboration happened, it really could decrease the family. And one of the things we learned was the environment really predicts, well, I shouldn't say predicts because that's a fun statement, really influences their perception of the experience. And so, for instance, as children sometimes change the setting, they might have multiple classes that they change to. They might have one teacher who's really, really good, and so in that class they have a really good experience, and then they go to another teacher who is not understanding, and that can be a bad experience. or they can go from one school to another school, and depending on if it's good or bad, it can change completely. And I had 8 children who went on to college, even though they were told they could never go on to college, and they all reported that it was a really good experience because most universities have accessibility offices like we do here at the university. And they said that, you know, professors are much more understanding about the you know, adapting their classes and being accommodating. And they said, you know, even my peers seem to be a little bit more understanding. So they actually had good experiences when they went to college. And so then that data that I had, where we were doing the mixed methods synthesis, I had extracted those studies, but I didn't have any funding to do anything with it. So I submitted an RR1 proposal to be able to update that search, because it ended in December of 2011. So we wanted to be able to do another search to add to that and do more extractions, and then have the money to be able to do all the effect size calculations and everything else that needs to be done in that. And so I submitted that in June after getting the faculty position. And it was, we got the results back and it was scored, but it was not funded. And one of the primary concerns was that I had not published a mixed method synthesis before. So we were like, wow, okay. So Dr. Knaffel also had some other data that they had dropped from their study, because they ended up dropping the conditions where the disability was either cognitive or behavioral, because they realized that to compare across conditions, it would be very difficult to compare something like diabetes to something like traumatic brain injury or cerebral palsy. So they had done this search for cerebral palsy, but they had not extracted any of the data or done anything with it. And so we decided I would take that and try to carve out some meaningful piece and come up with a meaningful publication. And I've just hired 2 research assistants to start extracting that data and find something to get out of that so that I can get that published and then turn around and resubmit the RO1 for the traumatic brain injury, which is what I really want to do. So, and the other piece that I was able to do was that 3rd secondary analysis, which is a piece of nurses being a really important conduit of information and help for the families, because they're at the bedside all of the time, and they're the only provider that really is with the families as much as they are. So if they were aware and had the skills to be able to do that for the family, it really could help the family. But if they weren't, then they were part of the problem. So I wanted to write that up in order to be able to help my peers learn how we could make it better. But it also talked about the system problem, which is a lot of times when the families get discharged from the ICU, they're not quite ready for rehabilitation, and so they're still in the later stages of coma, and so they go to a medical or a surgical floor, and they have things, well, they're in the later stages of coma, so they're a danger to themselves. And they're also, a lot of times, have brainstorming, which is where the sympathetic nervous system just kicks into gear all of a sudden. Their temperature can shoot up, their heart rate can shoot up, and it can actually be very dangerous to them if it's not dealt with. But unfortunately, a lot of nurses on these other floors do not know how to handle it, or they're not staffed so they're able to handle it. And so the parents feel like they have to be at the bedside 24/7. They're scared to death to leave their child. And so this becomes a burden for them that we put that on them, and they have to do that. So I wanted to challenge the healthcare systems to consider that and start taking that into account so that we take that burden off of them. And one of the things that I've been able to do is start mentoring some students. And I had a student from Armonk, New York, who's at a high school. It's a private high school where they have to start doing a research project. And so they have to do a lit review to identify a problem, and then they have to find somebody to mentor them. And she contacted me, and she's a traumatic brain injury survivor and was a gymnast who had a traumatic brain injury and then is about 3 years out now, I think. And she read my studies, And she was really excited about it because she felt like it was the first thing that really got at what she thought she went through. And so she wanted to know if she could work with me on my research. And I said, wow, this is really serendipitous because I want to take that data and look at that difference between the children's first interviews and second interviews. And why could they be so positive, and what do we need to know about that? So I thought, what a really cool idea to have her be the insider and I'm the outsider, and together we analyze that data and find out what we can learn from that and how we can help children. So she's going to do that with me. And then I have a bachelor's degree honor student who's looking at the memory gap that children have. And it's a really common thing for people to take pictures or have diaries. And the assumption is, oh, of course the child's going to want to know about that information, but some children find that very distressing. So for this particular condition, we need to help others understand there might be a reason why you could do that and offer that to the child, but don't assume that they want to do that. So my thoughts on why we might want to include qualitative research, and I don't mean qualitative research alone, but perhaps mixed methods studies where you have both quantitative and qualitative perspectives. That one is, if you've ever interacted with me by email, this first quote is something I have on my signature line of my email, which is from Ralph Nichols, who spent his life researching what is listening. And it's not hearing, it's something more than that. It's really suspending judgment and really hearing what the other person has to say, considering it, and then responding appropriately. So he says we must face with courage the fact that when we succeed in hearing a person out, our own position may be quite modified, and I certainly have learned that from the work that I have done. And then the other is a quote from this student, high school student, Mackenzie Schmidt, and I have her permission to share this. And this was her, something she wrote me in an email. She said, I was a high-level competitive gymnast who had just gone international, was on a path headed towards the Olympics. In a split second, the reality was gone forever. I was lying in bed, unable to tolerate any light or sound, unable to balance when I put on my feet, and could not retrieve the words I was trying to say. If you would have interviewed me then, I would have been extremely angry, resentful, and sad. 2 years later, after missing a year of school and spending time in rehab, relearning many basic skills, just to become functional again and learning that I would never return to my sport, my reality on life and my perspective on my future changed. I no longer was dreaming of the Olympics. I was focusing on a new way to define myself and my reality. I had, in a sense, pressed the reset button. I started completely over with a new self, a blank slate. My new self had no choice but to look forward to what was possible for me now. This allowed my outlook to feel more positive. A TBI survivor has a future ahead of them, some better than others, depending on whose perspective you are looking at it from. There will always be a longing for their old everydayness, but there is a part of them that has no choice but to move on to a new life, reset themselves, and make that life exciting no matter what is in it, their new everydayness. And so I just, what you see is that as humans, we have a propensity to look for the positive, and when we lose that, we lose the ability to go on, and we don't want that to happen. But it's, we need to understand that, because if you read a lot of the literature in TBI, we're very good at focusing on the negative, and we haven't been focusing on a broader understanding of what's been going on. And so I think that's what we can do by incorporating qualitative research into future research. So I just want to say thank you to all of the awesome mentors over the last 15 years that I have had, and I have mentioned them throughout this talk, and just say thank you, and I'm happy to answer any questions that anybody has.